Well, good afternoon, everyone, and welcome to the Intersection. My name is Anton Gunn, and I am an advisor to the Intersection and moderators for today's panel. Now, the Intersection brings together leaders in community and leaders in healthcare to share resources, experiences, and inspiration. So if you work at an advocacy organization or a healthcare organization, this is the place where you can learn from each other. This is the place where we can grow together. It's a safe space with others who are doing equity work in different capacities. So you'll face all unique challenges on your own, and it's the differences that we bring to this work that we bring together that makes this community so impactful. Everyone has a different insight, and that insight can help other people. And as I look back on my career, starting as a community organizer and later in a career as a chief diversity officer for a health system, I know how hard it can be to garner support for health equity efforts. That's why I know whether you work in healthcare or advocacy, moving the needle is nearly impossible without real buy-in from a CEO, from the healthcare CEO. But CEOs can't do it alone either. We all know that. Advancing anti-racism requires collaboration between all partners, advocates, and health systems. So I'm excited about today's conversation. But before we dive in, I got a couple of housekeeping items that I want to manage with everyone. So number one, please add your questions into the chat throughout this discussion. I know there are going to be questions, and we want to hear those questions. We'll record a podcast after this session is done, after we do this panel, and we will make sure that we answer those questions in the podcast. So that gives you another reason to come back to the intersection. And I hope you will stay on for the breakout sessions that we will have after the panel. These breakouts are an important opportunity for you to connect and meet with other people who are doing this important work. So if you plan to stay for the breakouts and need to be in a room with an ASL interpreter, please send a private chat to event support. So again, if you need ASL support, please send a private chat to event support, and we will make sure that you get into a breakout that has that provided for you. Now, I'm really excited because today's panel are some awesome individuals who are incredibly impactful in their own lanes, in their own world, and I get the privilege of having them to participate in this discussion with me. So I'm honored to be joined by Dawna Goode-Ledbetter. She's the Director of Equity at West Marion Community Forum in McDowell County, North Carolina. Early in her career, she worked at a senior center, so she has an inside view of how healthcare works. And she's now working to enhance the quality of life for residents at the only Black-led nonprofit in her county. And I also have with us Deborah Grimes. She's a Senior Vice President and Chief Diversity Officer at Ochsner Health in New Orleans. And she spent more than 30 years at the University of Alabama at Birmingham, where she held several positions, including her very first position as a nurse. And so Deborah is one of my heroes, if you will, for how she's had an impact in this work. So I'm excited about hearing from her today. In addition to that, our leader, CEO leader, is Joe Locke. Joe is the president and CEO of Eastern Iowa Health Center. It's a federally qualified health center in Cedar Rapids. He previously worked at several nonprofit organizations serving residents across the state. And I'm excited about Joe being here as a CEO to give us that perspective. So I want to go ahead and jump in and get started. And my first question is going to be for you, Dawna. And I want to talk to you about, your work. So you work with community leaders, hospital leaders, and stakeholders to advance health equity. So in thinking about engaging a CEO or other healthcare leaders, in your experience, tell us what works well and what's been a top barrier for you.
So for us, it's relationship building. Folks need to be proximate to each other because these folks in our communities, they have the lived experiences, they know what the issues are. And if you're not engaging with the folks that's experiencing these issues, then you can't really find solutions to the problem or come up with equitable solutions. So relationship building is key. We do a lot of events. We're event driven. We have a lot of town hall discussions, and we always make it a priority to invite leadership from the hospital and the healthcare systems in our county So just trying to make sure that, they're getting out of their comfort zones and coming and meeting folks where they are, because that shows that you're being authentic and genuine about trying to build these relationships. One of our top barriers, our hospital was acquired by another hospital system. So we've had 3 CEOs since we started this work, and we just have a new one that's starting. So that's been one of our challenges. Once you start the relationship building, and then there's turnover, and then you have to start the process all over again. So that's one of our bigger barriers. And then one of the real big barriers is that some of these institutional folks think that they're supposed to be the person in the front of the room speaking. And I can give a quick example of that. When we were trying to get the grant through Robert Wood Johnson's, my colleagues, and big shout out to Kathy Ariola and Ruby Marr. I think they're on here, so they've been doing the groundwork. But we had asked for a letter of support from our current CEO at that time, and they didn't want to support the work. But after we got the grant, now they want to be a part of the work. And that person made the comment, well, if I come to the meetings, or when I come to the meetings, I don't want to be in the front of the room. And our executive director's response was, well, who said you were going to be in the front of the room? So sometimes you got to check folks, and we all need to check our egos at the door, because we're all experts and learners at the same time. So we can learn something from people in the leadership positions, and they can learn stuff from the community. So that's just some of our ways we engage, and then some of the barriers that we have experienced.
Fantastic. I thank you for that. And I heard very clearly relationships, and also making sure that we're learners at the same time. We all stay in a learning mode. Joe, it's nice to speak with a CEO. I want to bring you right into this conversation. You're heavily invested in health equity work, and you got a strong understanding of your community's needs. And so briefly, what has been your journey and motivation for advancing DEI efforts in your healthcare system?
Well, thanks, Anton. I appreciate the question. And you talked about that health equity is really, it's not a destination, it's a journey. And we've been on this journey for several years. And, the journey requires everybody. It requires community leaders, healthcare professionals, and very importantly, healthcare leadership. And, that if the message comes from the top of the organization, that, and it's a consistent message, and it's a message that is strong over time, and like I said, consistent, then that it's a priority, not only for healthcare leadership, but for every single person in the organization. Because CEOs have a responsibility to help advance DEI efforts, because we can create pathways to change and advancement. And that's very important.
Fantastic. Thank you so very much. Deborah, I want to bring you in. Like I said, you one of my heroes, because you, like me, have played a lot of different roles inside of an organization. So you worked in a lot of positions, starting your career as a nurse and then moving through a wide variety of roles. So I want to ask this question for the clinical leaders who may be on here and trying to figure out what they can do. So what can healthcare workers at any level of any organization do to help to engage their CEO or other C-suite leaders in advancing equity efforts? What would be your response to that?
Good afternoon, Anton. Thank you so much. That's a very thoughtful question. As I listen and reflect on the great panelists that I'm privileged to join with, they've hit on them. It's about relationships. It is about leadership. In healthcare in particular, especially when you're talking to clinical leaders, it is so important to not separate this work from great patient outcomes. And if you're just starting this work, or if you're thinking about how do I get started and how do I create those synergies, I strongly encourage you to read the IOM report that was written some 20 years ago. It laid the foundation in a very data-driven way, in a very clinical way. Because if you're talking to physicians, nurses, CEOs who have to lead, they really do understand that in healthcare in particular, it's all about outcomes. And when you look at outcomes and you start to stratify the data, you will see those health disparities clearly. You will start to see them. And then as you start to address health disparities, you will then see that because the reason you have health disparities is because of all of this health equity. And when you think in terms of health equity is really those external social determinants that leads the patient or the community coming in to have barriers to reaching those great outcomes that we all want patients to have. So it really starts upstream. It doesn't start once the patient's in the bed or once the patient's in the clinic. It starts with, how are you developing a trusting relationship with community? So to your point, you have to meet the clinicians where they are. Is it lack of awareness? If it is, you have to get them aware quickly. Is it lack of education? If that is, you have to educate them. Once they have an awareness and once they're educated, then you have to provide a strategy or a roadmap to help them to be able to address the needs. And then we all come on common ground. How are we going to implement these things? And that's where they're looking for leadership to partner, to create strategies, to remove barriers, to help have the technology, to help work in the community. It's a complicated process, but it actually starts really simple. It's understanding how the clinician works. All clinicians, nurses, respiratory techs, pharmacy, we all go into healthcare because we want to help patients. We do it in a lot of different ways, but that's where you start. You have to connect this work to the patients that we have the privilege of serving.
Great. So you talked about data as being a way to, connect everything to outcomes. So Joe, this question is really going to go back to you on your evolution and your journey as a CEO and a champion for equity. Talk a little bit about the role that data meant to you as a leader, and were there any particular metrics that an organization could focus on that would have an impact, and how you get a CEO engaged in the conversation? Just share a little bit about your perspective there.
Absolutely. For us, we don't do anything. Let me rephrase. We always do everything with one thing in mind, and that's our patients and health outcomes. And so talking about data specifically, we had 46 languages spoken. So keep in mind, we're in Iowa, right? We're a flyover state. And yet 88% of Iowans are Caucasian. And yet 55.5%, talking about data, 55.5% of our patients are people of color. And so, and once again, a data statistic that's accurate is that 77% of our patients are at or below 100% of the federal poverty level, which is $31,200 for a family of four, 77%. And so, people think of, okay, so that's pretty fascinating, right? Well, what I think is fascinating is here we are in Iowa, and that after English, the most spoken languages in 2023 calendar year were Swahili, and then Spanish, and then African French, and then Kirundi. And so, we really do pay attention to the data, and we use that patient lens for every decision that we make, because it's all about the patients.
Wow. So first of all, I just heard some incredible statistics, and I think it validates what Deborah said, that understanding your patient population, you can't deliver great care if you don't even know who you're serving. And, just to understand in Iowa, Cedar Rapids, Iowa, that the second most spoken language is Swahili, or the first most spoken language is Swahili over Spanish, is mind-blowing to me. And I think that's important in understanding around data. So Dawna, I want to ask you this question. If you're in a community where you're having CEOs transition in and out, what story are you telling with data that has been compelling with the leadership of that institution, or been compelling for a CEO that will get them engaged? So give us some sense of how you're using data.
So we use stories as our data.
Very good.
Our organization is fairly new. This work is fairly new. So, and we do have some stats and things that we use, like when we're having our community meetings, but just the stories of the folks, we did some surveys, between the Black and brown communities. Like I said, we're really event driven. So we had what we call cookouts, and each culture brought food from their culture, and we got some survey data, like, if they felt safe going to the doctors, what were their barriers, like language and different things of that, and just the general mistrust of the system. So we share those stories. And we've tried to embed folks into the patient advisory councils in the hospital. That's been a challenge for us, because with the turnover in leadership, and then the misunderstanding of equity in general, like where we live, equity is a bad word. So it's really a struggle, but just trying to use the stories to show that there are disparities and that we need culturally appropriate services, or at least the staffs of these hospitals and healthcare systems need to have the training to have the culturally appropriate services. So we paid for racial equity training for some hospital staff. Some people participated and some did not, but just continuing to offer those things and us pay for them and try to make it convenient for folks to do that. But yeah, that's kind of data we use, like the stories, just to show what the disparities are and the lack of understanding of the history of why our folks are having these disparities and why they have a mistrust of the hospitals and healthcare systems.
Very, very good. So,
Yeah, Tom, I'd like to
go ahead,
one
please.
thing, please. So one of the things, by federal mandate, as a federally qualified health center, 51% of our board of directors have to be patients. And so, that really keeps us grounded, because at every board meeting, we have board meetings once a month, and we have committee meetings throughout the month. Those board members that are patients say, this has been my experience. This is what's going on. Hey, did you notice this? And that is really impactful.
Very,
And
very
Joe,
good.
I'm sorry, but Joe, I'm glad you lifted that up, because like I said, it was a challenge with us, and we had a meeting with the lead persons at the hospital for those patient advisories, and they wanted to know why so many nonprofit leaders wanted to be on that advisory council, and because it was for patients. And like I told him, we're patients as well.
Right.
We're trying to create safe spaces for our folks to step into their power, to have the ability to speak for themselves. So until they get that safety and feel empowered to do so, then we're their voice as well. So, sometimes you have.
Anton, I'm sorry. I did want
please.
to follow up
Go ahead.
while we're talking about data, because I don't want to assume everyone has access to the data. And I don't want to say that getting the data is easy.
Yes.
I'm very fortunate here at Ochsner Health to have Dr. Ebony Price Haywood, who is a national leader for health disparities, and she spent a lot of time getting us accurate data. Because I don't want you to assume that the systems, whether you're on Cerner or whether you're on Epic, that they're set up to be able to do this automatically. And so I would encourage you to really find those experts that are out there that understands how you collect the data and understands the importance of that data being accurate and being systematic, so that you can rely on the data. Because what you never want to do is to get into a group of clinicians where the data isn't accurate. So I would want to point that out as well.
Yes, that's a great point. We're gonna come back to this. So right now, what I like to do, I want to pause this conversation and make sure that the audience lets us know if you plan to stay for the breakout groups after the panel is done. We will end by 3 p.m. East Coast time. And of course, we hope you all will stay to meet and share with peers. But we want to get a sense of who's going to be here for the panel discussion. So if you could look at that breakout poll, let us know yes or no if you plan to stay for the breakout discussions. That would be helpful. And continue to add your questions to the chat. I'm seeing some questions go in there. I see a good one from Raina that popped in, a couple of others that popped in. So I want to make sure that you continue to keep adding your questions to the chat. And then we're going to keep moving. So I want everybody to give a chance to make sure you let us know whether you stand for the breakout. I want to go back to what you all were just talking about. And I had a business mentor about 20 years ago say this to me, and it's going to inform my next question. He says, Anton, facts tell, but stories sell. Okay. There's a framework around, you can have all of the data in the world, but sometimes the data doesn't put the human experience to sell people on the idea of being able to make change. So I want to ask all of you, and I'm going to have you answer individually, if you had to sell the importance of equity work to a CEO that was not bought in, what would you say to them? What would be your elevator speech, if you will, to gain their involvement? And I'm going to start with, I'll start with Deborah.
That is a great question. I think personalizing it to say, we have an obligation as leaders to convene in this work, because it has to be personal. And once you reach a person with their personal connection to it, then it quickly can move into how. You know, as a leader, most CEOs of anything, they understand that leadership comes with responsibilities, and this work is so critical to the mission and to the values of a healthcare institution that it becomes an imperative. And that's what we have to connect to. The emphasis of, you have to do this work. It's not good to do it. It's not optional to do it. That if you are about great outcomes, and I have no doubt that CEOs of healthcare institutions, they have to be about great outcomes, then you have to be about addressing health equity. And then the question quickly turns to how.
Well, let's hold on to that how. We'll come back to the how. So particularly, Dawna, knowing that you've had so many transitions of leadership, you probably have had to do this 1, 2, 3, 4, 5 times over. So what would you do to sell them on the importance of equity work if they're not bought in? What's your pitch?
So my pitch is that it's our assignment to make sure that the folks that we live with are healthy and well, and that is a privilege that everyone should have access to the quality healthcare, regardless of their race, their lived experience, or their socioeconomic status. Because all of us on this earth, we're here together. It should be everyone's assignment to help take care of everybody, and regardless, no exceptions. So that's right. My pitch. So that's it.
That's good. Straight to the point. No chaser. I appreciate it very much. So Joe, you are what I would call an enlightened, impactful, and clear-eyed CEO around the importance of equity to meet the patients that you serve. But I've been around enough healthcare CEOs at large hospital systems and other places who may not be as interested or involved or committed, and maybe even to some degree resistance, because there is, some investment that you have to make. So what do you say to your peers who haven't been on the journey that you've been on? What would you say to them to get them bought into the equity journey?
Great question. One of the most important things is to be there and to be out there. And, I feel like it's the CEO's job to create the vision, to carry the torch, to be involved with other CEOs. And, when we started our journey, we called it our DEI journey. It evolved. And so now we call it JEDIB, standing for Justice, Equity, Diversity, Inclusion, and Belonging. And so, that's a conversation starter. And I will tell you this, that I have, when we started the journey, and leading this with my executive team and bringing it to every person in our organization, I bought everybody a bunch of T-shirts, okay, or I bought everybody the same T-shirt. And the t-shirt is a black t-shirt with big white letters. And I've got it here in front of me. It says 100% for health equity, 100% over racism. And you know, when I wear that t-shirt instead of this suit and tie, when I wear that t-shirt to the 13 boards of directors that I serve on, nonprofit boards, and they'll say, wow, tell me about that shirt. I mean, that's a real outward sign because, they're like, well, what is health equity? And it's all about, I say, you know what health equity is? Health equity is paying attention to your patient population and what their needs are. And if 77% of our patients, if they're not making more than $31,200 a year for a family of 4, then guess what? Every day is a crisis du jour. I mean, it's food insecurity, housing insecurity. It's, and I don't care if you're rich, poor, what color you are, all that. Everybody deserves, first of all, to be respected. Everybody deserves incredible dignity because we're all human beings, and everybody deserves a great place to go to the doctor. So we just opened in November a new $5.6 million dental clinic. So we'll go from seeing 10,000 patients a year, visits a year in dental, to 25,000. We'll see 73,000 patients in the fiscal year that's coming up starting July 1. And we just invested another $3.5 million into another one of our clinics because, we've got the nicest place to go to the doctor in town. And we're a nonprofit. And so, everybody deserves that dignity.
Well, Joe, I want to applaud you for the shirt and the willingness to wear it and to do it. And I can speak for everyone on that. But this is a great point from once a CEO might be there mentally and emotionally. The question is, what can a CEO do to support equity work? And I'm going to ask all of you this question, but I'm just, wearing a shirt is part of it. And that's a great first step. But thinking the context around a day-to-day CEO who has lots of obligations, lots of commitments, they're being pulled every which way by this clinician group or some other challenge. What are some ways that the CEO can actively support the equity work? What do you think they need to support the equity work? And I'll start with you, Joe, and then I'm going to go to Dawna and then finish up with Deborah.
Well, I believe that as I said, I believe it's our responsibility, and Dawna did too. I make sure that the hospital CEOs in and around my community, that I'm in their offices. I go to them, and I just say, hey, it's been a couple of months. How about I come by for a chat and 30-minute cup of coffee? And it's one of the things that, and I say, what are you doing in your hospital system with regard to Jet IB? And they'll say, well, what's that? And I'll say, well, this is it. It started for us as DEI and it's evolved. And so, just making that conversation happen is important.
Very good. Dawna, what about you? What do you think a CEO needs to support the work, and what would you provide?
I think that, just providing the opportunity for the folks that work for their system to take these trainings, to learn the history, to attend community events. We're having a week-long Juneteenth festival, and we have some healthcare providers that's going to come and have tables in our neighborhood. So when you get proximate to the folks that you're serving, that builds that relationship, that builds that trust, and that shows your authenticity. Like Joe's t-shirt, I love it. I love that he's bold enough to wear that t-shirt in spaces where people thinks he should have on a suit and tie. You have to walk this walk and talk this talk out loud at all times. And also the things that we provide is the safe space to do that, to come, because one of our things is we attack problems, not people. So we want you to come and hear what the problems are. We're not going to attack you because you're not doing the right thing, but we're going to hold your feet to the fire in love so we can come up with a solution to make this relationship better for the CEO, for the hospital system, and for the patients and the people in our communities.
Very good. That's a bar. We attack problems, not people. I need to put that on a t-shirt and a bumper sticker as well, so everybody needs to see it. So Deborah, talk to us about, you got great leadership where you are fully invested in the work. What do they need? What does the CEO need to support the work in a meaningful way?
So I think, just following up on the other panelists said, I think it's important to say that DE&I is important.
Hmm.
Say it in whatever venues that you are empowered to be able to say it. That's one thing. And then the second thing, I think this needs to be elevated to a board conversation.
Hmm.
So once the CEO is committed and on board, it needs to be talked about at the board level so that they are equally as educated and committed. The third thing then is you need to have an internal strategy and communicate to all of your employees, to all of your leadership, and people need to see health equity as a part of the overall system strategy. And then you need to give resources to that, because if it's elevated, it needs to have the same resources as finance, same resources as quality, same resources as operation, so that the goals that you identify, you can actually address. And then the last thing is external. So are you showing up places? Do you have community partners? Because we know we cannot do this work in isolation.
Mm-hmm.
For example, we partner with the Louisiana Urban League.
Mm-hmm.
That's a trusted partner. We partner with Xavier University. That's a trusted partner, because part of it is showing humility. We don't have all the answers. And it's going to take us working with community leaders, us reaching out saying, we want to improve the health of our state. How do we do that? We came out with a bold, healthy state initiative. And when you look at, I encourage you to look at the rankings of Louisiana, we're at the bottom in a lot of measurements. And quickly, when we start to look at that data, we realize we can't address those health rankings for our state and not address health equity. So we started to align this work. And then you have to employ and empower experts. I talked about Dr. Ebony Price Haywood. She is, she was already here and passionate about research, but giving her a team to work with to be able to not only have a strategy, but be able to partner with others in the organization to create synergies and actually implement change internally and externally. We have Dr. Laborde is our physician over community leadership. So there's just a lot of investment in allowing people to tap into what they're passionate about, but also giving them the resources to be able to make change.
That's great. And Deborah, you said, I heard you say the word community multiple times. And, coming from a beginning of my career in a long organizing tradition of community work, I know that sometimes there are obstacles that keep community separate from leadership in an organization. And so I like to spend a few minutes, and I'm going to start with Dawna on this one, to talk about what are some of those obstacles that keep CEOs and executive leaders from hearing directly from community members or even internal DEI champions. Because let's not assume that just because you're passionate about DEI inside of an organization, that there's a way for you to get to the leadership, because that would be a failed assumption, given that sometimes there's a disconnect between frontline and what happens at senior leadership. So let's talk a little bit about the barriers that might keep a CEO from hearing from a community on why this work is important and what needs to be done. So, Dawna, I know we've heard a little bit about transition and leadership being a big barrier,
Right.
but give me some others or some of the things that you've been challenged with as you've been doing this work.
So it's location and where you live, because like I said, diversity, equity, inclusion is not welcomed here with open arms. So people try to save face and their optics. They want to be in line with the people that has the money. So that's a barrier. And then just the institutionalized way of thinking. People need to shift their thinking And because if the things that we've been doing for so long were working, then there would not be any disparities. We wouldn't have the need for diversity, equity, inclusion things to be taking place. So that's a barrier as well. And then the community, the barrier is that you know, some folks do not feel safe talking to people in institutional spaces because they've never had the opportunity to do that. So and that's why we try to create a safe, neutral space for everybody to come together and meet each other where they are. Sometimes we go to the hospital and have meetings, and then sometimes we invite them to meetings in our communities. And I know time is a constraint for some folks too, because, you know, those workers are overworked and things of that nature. So just giving folks grace. But it is a struggle, especially when you've had the turnover that we have, and you have to keep going back to the drawing board and seeing you know, what this person's perspective is. Because some people, you're not going to be able to change their mind one way or the other, and that makes it harder. But as long as we keep showing up and showing out, you know, we're going to get the right folks to the table. And it might not always be the CEO that we've learned. Sometimes you got to just invite the people, like the people that work in the practices, the front desk people. We have those people come to our meetings and be panelists and talk about their issues and how they interact with people on a diversity, equity, inclusion level. So sometimes, you know, you don't need the CEO, and that's just real talk.
Very good.
I have a
Joe,
couple of things to add, if you don't mind.
please go ahead.
Based on
Yes.
what Dawna said about learning. A couple of years ago, I invited the head, the executive director of the ARC of East Central Iowa, and their clients are people with behavioral and cognitive disabilities. And so she started her presentation off in front of my board by saying, "What do you suppose is the most discriminated against group in the country?" And and she allowed like 30 seconds. There was a pregnant pause. And I have to tell you, I was surprised about the answer. And it was, she said, without a doubt, it's people with disabilities. And the Americans with Disabilities Act, you know, made a tremendous difference about that. But she said, you know, one of the things that we need help with, and she literally asked for the help. She said, we need help. We need to help the parents of these of their kids with these physical or cognitive disabilities once they become adults, and especially those with that, you know, they may be 30 years old, but they may have the mental capacity of a elementary school person, right? And so we worked with them. So the board of directors said, "Okay, Joe, there's your marching orders. You know, about in the next year, we want to help them because we have a very robust OBGYN and maternal health program. And so we help them develop curriculum that's now being used nationally with other like organizations, because we have OBGYNs. I mean, you know, we deliver between 600 and 700 babies a year. And you know, we are a Title X provider. So we provide free contraceptives in 3 different counties to low-income women and men. And but, you know, it was you know, that curriculum wasn't for the kids. It was for the caregivers and the parents, because, you know, they were in denial a lot of times. And, you know, you know, another example is in February of 2022, Lynn County, Iowa, where we reside, received 253 Afghan refugees. And so we started having Saturday clinics for family medicine, pediatrics, and dental. And because, you know, a lot of those Afghan refugees did not have either, so they were coming into the country legally. Although, you know, if someone is undocumented, if you can't pay, we treat you anyway. That's our motto. But so it got to April, so we were having these Saturday clinics, and everybody was showing up for their family medicine appointments, and everybody was showing up for their pediatric appointments, and the dental staff was just standing around, and nobody was there. Well, guess what? It was Ramadan, and people don't want to put things in their mouth during the day. It's just like, you know, we think we're so advanced and evolved, and yet I learn something new every day. And so, you know, it really is a journey.
Yeah, very, very good. That's, man, so insightful, and your experiences are very impactful. I want to, you know, kind of bring us to, I got a couple more questions I want to bring us to. And this one goes back to what we talked about earlier around the board needing to be involved. And I use this quick analogy is that, you know, as a parent, I'm a parent of a child, and sometimes my child doesn't listen to me. My daughter doesn't listen to me at all. When I'm trying to give her some great advice, something that's going to make her better and make her successful, she has no interest in listening to me whatsoever. However, my wife could say it, or a cousin could say the exact same thing, and she hears it totally and clearly and gets it. Sometimes CEOs may not hear from community or may not hear from people internally. So can we have a few minutes of discussion around who does a CEO listen to, and how might we influence the person who we need to influence? And I want to hear your experience and perspectives around that. And I'll start with you on that, Deborah.
Yeah, I think influence in this work is incredibly important. And I think you have to have organizational awareness, and you have to understand if, you know, I'm really privileged and blessed to be able to sit on the executive team. So I have direct contact. But I do realize that not everybody has that ability. And so then I would really strongly suggest that you assess your organization. And in healthcare in particular, CEOs have to have great relationships with physicians. And so then I would try to connect with physician leaders who have direct impact on patient outcomes and seek that alignment that way. Most organizations have to have nursing leaders, which have incredibly direct impact on patient outcomes. Seek that alignment. Sometimes it's the strategy person. And you get my point. I think you just have to assess the organization, and you have to figure out, who do I have to align with that does have the ear of the CEO? Mm-hmm. And then do all the things we just talked about. Increase awareness, share with them the data so that they could be your voice with the CEO until you get a voice. Yeah. And the point to that is that we don't have to think we don't have any power if we don't have a seat at the table. We still have to figure out how to have a voice at the table.
Yes.
Until we get the seat.
Great. That's great. So Joe, since you are the CEO here, just go ahead and tell us all of the secrets. Who has the most influence over you?
Well, I have a lot of input from a lot of different places. So, you know, when you think about my board of directors, so technically I have 15 bosses, right? And knowing that at least 8, if not, it's actually 10 out of those 15 people are patients. And so, you know, I get a chance to interact with them frequently, and that's really important. Of course, my senior leadership team, of course, my regular leadership team, but, you know, it's important that, I mean, so we started a very robust onboarding process about 6 months ago. And so, you know, I get a chance to meet with every single person as they onboard for a couple of hours, and, you know, and get to tell my story, and get to tell, I don't mean my story, I mean, get to tell Eastern Iowa Health Center's story, and why that patient lens is so vitally important. And that is the fact that, you know, we want to live the mission every day. And our mission is very simple. It's 4 words: exceptional healthcare for all, everyone.
That's fantastic. Well, Dawna, I'm going to give you the last word on this. Have you found in your work that there are some other people who have influence over the C-suite or the CEO leaders in the organization? And have you been able to build a relationship with them?
That's a good question. And I'm not really sure, but this is my suggestions for CEOs or whoever. You know, if your influence is your board or your advisory councils or whatever, make sure you have a diverse board, not just have check the box off folks sitting at your tables, because a lot of people will do it just so it looks like optically that they are practicing diversity, equity, inclusion. Well, we got a Black person, we got a Hispanic person, and we got this, da 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 da, and it's just check the box. And you think those folks are just sitting at that table just so you can check off your boxes. So make sure you're not doing that, that you have people that really want to be at that table, eat what's at the table, and digest it and give you some good feedback on whether what they ingested was good. And so for communities, I know Deborah talked about being at the table. Sometimes we got to build our own tables and bring the chairs and the plates and the silverware and all of that stuff, build our own tables. And if people in community are building tables to bridge the gaps and build these relationships, then go have a seat at their table and eat what they're serving. That's my last word.
Thank you. Well, this has been great. So first, I want to ask the attendees something. So attendees, we have one final poll that we want you to participate. So the intersection really is a community, and we want your help in identifying future topics for us to discuss. So we're going to put some topics on the screen. We want you to rank these possible topics based upon your personal interests. And that's advancing equity in rural communities, diversifying the healthcare workforce, building trust through community health workers, using data to advance anti-racism in healthcare, and what does it really mean to be a health equity leader, or the politics of language, and how do you talk about DEI, equity, and anti-racism? So let us know, like, which do you have some interest, no interest, extreme interest in? Please rank all of these topics. And also, if you have recommendations for speakers for any of these, or anybody that we should feature as a part of the intersection community, whether it's yourself or someone else, please, please, please email us at info@meetattheintersection.org. Again, info@meetattheintersection.org. We love to have speaker recommendations, panelist recommendation, whether you or someone else. So please make sure you complete the poll and send us some information if you have some recommendations. Now, for my panel, we could probably talk all day, because there's so much more I want to ask all of you and talk to you about, but it's time for us to transition to the breakouts. So I want to first thank you, Dawna, you're the best. Deborah, you're the best. Joe, you're the best, for being here and sharing your insights with all of us. If you all want more updates about what we're doing at the intersection, make sure you sign up for updates at meetattheintersection.org. So make sure you go to meetattheintersection.org. Stay tuned for more information about upcoming events that we'll be doing. And we hope you will stay for these breakout groups. We think this is a great place for you to build community. We want you to build community. And if you cannot stay, please take 1 minute to complete a brief survey, share it in the chat. We're going to give you a survey, share it in the chat. We want to get some feedback from you. Feedback is important. And if you can't stay, just give us a feedback and roll out. But if you can stay, we want you to stay. And so we appreciate you exiting so we can know how many breakouts that we need to put together for everyone. So what we're going to do here, we're going to take a short 5-minute break so we can set up the breakout rooms. So you have time to go take a bio break, grab some water, grab whatever you need to do. We're going to take 5 minutes and we'll go to the breakouts. But again, thank you all for being here at the intersection for this panel discussion. And we will see you on the other side, either in the breakout rooms or the next time that we have an intersection event. So thank you very much.